I just want to say welcome again. We are giving it a few minutes until the hour for folks to join and get set up on WebEx. We're really looking forward to talking with you all, so we will be started shortly. Hello, everyone. It is now 1 p.m. Eastern Time. You have joined the webinar on Intercepts 0 and 1, Diversion in Practice. To allow for additional sign-ins past the hour, we will start the webinar in a few minutes, but I just wanted to turn everyone to your chat box on the lower right to give you a few pointers on Q&A and also technical audio problems during the webinar. Please contact the WebEx technical support team. There is a phone number below. Well, good afternoon, everyone. I am Julia Kessler, Project Manager at the Council of State Governments Justice Center, or CSG Justice Center. Thank you so much for joining today's webinar. Today's webinar is funded by the U.S. Department of Justice, Bureau of Justice Assistance, and done in collaboration with the Policy Research Associates. To give you an overview of today's webinar, first I will introduce our speakers. Then there will be a brief overview from CSG Justice Center and the Bureau of Justice Assistance. After that, there will be a brief overview from PRA, and we will go into our introduction presentation on intercepts 0 and 1. We will then transition to the presentation and discussion from our panelists, and today we are joined by panelists from Middlesex County, Massachusetts, Pima County and Tucson, Arizona, and Athens-Clarke County, Georgia. During the panel discussion, audience members can ask questions to the panelists and speakers. However, throughout the presentation today, we do encourage you to send questions on your chat box, and we will be monitoring them and answering them during the discussion. Finally, this will be followed by a quick closeout, including additional resources. And of course, we will be sharing those resources and links afterwards. As I said, anytime during the webinar, you can ask a question by typing it into the panel. This includes both technical and content-related questions, although if you do have WebEx technical access issues for video or audio, please do access the phone number that was shared. We will do our best to go through as many questions as possible at the end during the panel presentation and discussion portion. By way of introduction, my name is Julia Kessler, and I'm a project manager with the CSG Justice Center. And I manage the Justice and Mental Health Collaboration Program Purpose Area 1 grantees. As a project manager for the law enforcement team, I also manage the JMHCP and law enforcement support centers, as well as the law enforcement mental health learning sites. Prior to coming to CSG, I worked at the National Police Foundation, providing evidence-based programming to law enforcement around the country. I am very lucky today to be joined by my PRA presenters, Reggie Hooter and Lisa May, who will be introducing themselves later on and will be sharing their presentation. For those of you who don't know, who have just joined us, by way of introduction of the Council of State Governments Justice Center, the Justice Center is a national nonprofit, nonpartisan organization that combines the power of membership association representing state officials in all three branches of government with the expertise of a policy and research team focused on assisting others to attain measurable results. Our staff develops research-driven strategies to increase public safety and strengthen communities. This is a bit of how we work, but at the Justice Center, our core values include a commitment to being independent and nonpartisan in every aspect of our work, providing rigorous, trusted, high-quality analysis, developing practical and innovative solutions informed by data and research, promoting collaboration and building consensus, and being inclusive and respectful of diverse views and experiences. CSG Justice Center's goals are to break the cycle of incarceration, advance health opportunity and equity, and use data to improve safety and justice. The Justice and Mental Health Collaboration Program is a grant program which is developed to promote the collaboration across criminal justice and behavioral health systems from law enforcement, pretrial courts, jails, and community supervision. And this webinar is funded today by the Bureau of Justice Assistance, the Department of Justice Bureau of Justice Assistance. I'm not going to read out BJ's mission, but we did just want to share that they are a funder today and we couldn't have done this work without them. So before I turn it over to PRA, we have one poll question. This is the question I just wanted to share with you all. And with that, I will turn it over to my colleagues, Lisa and Reggie.
Thank you so much, Julia. So on the screen, you have a poll question, and it is entitled, do you have a cross-discipline program? So to the right of your screen, you will see that question. If you could please take the time to submit your answer, we will tally them up and then give the results. Throughout our presentation, we're going to be talking about cross-discipline programs and cross-systems and how, I guess if it's synonymous to a multidisciplinary team meeting in the medical field, is how we're going to make that analogy with how cross-systems working with behavioral health providers and criminal justice stakeholders really enables the effectiveness of service delivery. So you still have a few more minutes. Cross-discipline meaning that we have the community behavioral health providers. We have law enforcement, which would include your 911. We have the jail systems. We have the court systems. We have your community supervision. Every single discipline that you can imagine would be within our intercepts between 0 and 5, mainly between community behavioral health providers, law enforcement, 911, your jail systems, and everything that incorporates, in addition to your attorneys, your prosecutorial system, your defense system, your court system, if you have any accountability courts, supervision, your jail, behavioral health and medical providers, in addition to your community supervision. So we have a few more seconds, and if we, Janice, do we have a percentage of the amount of individuals who have answered the poll? Okay, here we go. So the poll is closed, and the results are that 51% have stated that you do have a cross-discipline program operating within your jurisdiction, and 4% have said no, and 45% there is no answer. So out of half of you, you have let us know that you do have a cross-discipline program. Next slide, please. So good afternoon. My name is Lisa May, and I am a Senior Project Associate with PRI since 2019. I provide technical assistance, meeting facilitation, and project management to jurisdictions involved in the MacArthur Safety and Justice Challenge, especially to those jurisdictions that have developed behavioral health and criminal justice strategies. I also help facilitate sequential intercept mapping workshops, in addition to trauma training, train the trainer, and I'm here with my colleague Reggie Herder, who will introduce herself. I currently am in the outskirts of the city of Atlanta, or in a local suburb, Henry County, for those who know Georgia. And prior to coming to PRA, I was a faculty member with the University of Georgia, providing technical assistance and project management to JMHCP program recipients. And prior to working with UGA, I was the Deputy Director of Mental Health for the Department of the Georgia Department of Corrections. So Policy Research Associates, our national expertise. So we are a certified women-owned small business. We are a national leader in behavioral health and research. With our expertise, we do offer 4 core services that help individuals with behavioral health needs. And those 4 core services are technical assistance, training, research, and policy evaluation services. We pride ourselves in educating communities on meeting the needs of individuals with mental health and substance use disorders. Next slide, please. And you have our website right there on the screen. So I won't go through the entire rundown of today's presentation, but we will start off with the sequential intercept model and talking a little bit about this conceptual framework. So I'm now handing it over to my colleague, Regina Herder, who loves to be called Reggie, and she will introduce herself and go through the next few slides.
Thanks, Lisa, and hello, everybody. I'm coming to you from Denver, Colorado, where I worked for over 40 years developing system change. Started using the sequential intercept model actually in 2006. It was actually developed by Patty Griffin and Mark Munitz in 2005, 2006, and that kind of time frame, really as a way, a conceptual framework for communities to look at how their system is really working when you're considering behavioral health and criminal justice. So it really becomes an organizing tool. If you'll go to the next slide, please. I'm going to go through a series of slides that really is focusing on Intercept 0 and 1. What you see in this layout is, and Lisa kind of talked about the different stakeholders across the SIM, as we're going to refer to it, the sequential intercept model, the SIM. But it really goes from Intercept 0 to 5. So in Intercept 0 and 1 is really about crisis services where we have an opportunity to deflect folks out of the system, and then also that initial contact with police when there's legal action that's probably going to be taken. Intercepts 2 and 3 really starts to bring in the court system and the initial detention, and that might be in a detention center or a jail facility. And so there we're really looking at bail, we're looking at pretrial services, initial court hearings, those initial identification of needs when folks are entering the jail, dispositional courts and in particular treatment courts, and then also starting reentry services, which goes into Intercept 4, and then in Intercept 5, really looking at probation and parole. One of the things I want to note on here is there's a little bar across here that says cross-system data analysis. And I always want to make a note that as we're looking at systems and as we work across the country, one of the things that's very important is that everybody's got different pressure points, and to look at your data to help identify where it is that you actually need to really build some strategies, some opportunities for change. I also would say, and my colleagues know I do this all the time, but I think about the sequential intercept model as really being a riverbed. So when you think about a river, and you think about, depending on the size, the width of the river, and you think about how much water's coming through it, but you also think about those kind of rocks and trees and different kinds of debris that sits in the water. Those really are things that help to shape the flow of your system. So when we use data to help inform our process, then we can really figure out what kinds of services, what kinds of programs do we want to have to really help manage the flow, the needs of our particular community. If you go to the next slide, please. We again are just going to focus in today's presentation just on Intercept 0 and 1, the opportunities to deflect people from the criminal justice system to services, and then also the role that law enforcement plays in Intercept at being both warriors as well as guardians. So if you go to the next slide for me, please. I put together this slide because oftentimes we tend to think about certain things that people might do, again, programs that we might do in Intercept 0 and 1. And I wanted to try to create a visual of looking at Intercept 0 and 1, not just as a thing, but understanding the flow. And so there's 4 major areas here: pre-crisis, crisis, stabilization, and recovery. And the importance of understanding that those are not necessarily a linear process, but in fact that when somebody is even in that recovery setting, that they may be triggered. There may be things, events that take place in their life that put them back into kind of being less stable. And now they're back into pre-crisis. So always understanding how our system is working. David Covington talks about being an air traffic controller and making sure that we know in that particular instance, and traffic controller knows where the plane has been, what are they doing with it, and how they're handing that person off or that plane off. I'm inviting all of us to take on that same attitude and values and beliefs, that we all have to be air traffic controllers. We have to mind the flow of where people are going, where this person has been, what kinds of services have they received or not received, what are we doing with them, and being very intentional about how we're handing this person off. And so as we look at this particular slide, without going into all the different levels of it, that we want to recognize that there are crisis and emergency lines. And that in many times now, there's embedded clinicians that are in those 911 call centers. And 911 call centers, we'll talk a little bit more about them later, but are really instrumental in helping us understand the nature codes of what kinds of calls are coming in, the volume of those codes, and the location of those codes. Again, using data to help inform what kinds of strategies we might put in place. Want to look at community-based triage. There's a growing interest in alternative health models. CAHOOTS is really in Eugene, Oregon, is what a lot of people refer to that as. But there's a lot of communities across the country are starting to look at how do they look at whether it's their fire community paramedics and a clinician coming together to be able to provide services, or through an FQHC, a federally qualified health center, or to have co-responders, a clinician that's rolling with police officers, or in some case with fire, to be able to respond to community-based needs, those areas of work where people are in crisis, but it's not necessarily a criminal justice issue, it really is a crisis issue. And then looking at how other types of teams like homeless outreach and other kinds of teams that may be responding in your community. Hospitals, we have to always be mindful of hospitals as a very precious resource, and not putting people into a hospital setting. They're going to be boarded there, they're going to be stuck there. So always want to think about all of this again as a continuum of where people are coming into and how are they flowing through the system. But also recognizing Psych-Based Stabilization. A lot of places have developed, whether it is a stabilization center that's short-term, that's walk-in, where people are voluntarily coming in, or it's something that police bring in, and you'll be hearing about some of those stabilization centers later on. Substance use disorder around detox or sobering types of centers, making sure that there's what I would call treatment on demand. So when people are needing to have treatment, that they can get into it and there's not huge waiting lists. Also looking at transitional types of services, and then onto ongoing kind of more recovery-based stabilization centers. Whether we're looking at kind of ongoing kind of peer run types of centers, or we're looking at kind of models like a living room model that might be more of a stabilization center, but also can look at and provide ongoing kind of respite care that helps to prevent somebody from going back into pre-crisis. So one of the key things I would also want to remind us of is there's a population that's often a part of all of our systems that I'm going to refer to as the most visible persons, or MVPs. We want to be mindful about what we're doing to try to address their particular needs. Oftentimes those persons are also living and experiencing homelessness and have a lot of complex care needs. So how do we really wrap around them? If you go to the next slide, please. So there's some really critical parts about building coordinated care. A couple of those, again, is data to understand needs, making sure there's cross-system coordination across the different stakeholders, that you have adequate funding and resources, that your policies are supporting the infrastructure and the use of all the different resources you have, and that you have workforce that can actually deliver those services. If you go to the next slide, please. There's a lot of, it's important to have unifying principles. Dr. Balfour is with us today, and some of these things are things from some of the things that she often talks about. I want to remind us that if resources are not timely and accessible, what is a crisis is going to turn into an emergency. So we always want to make sure that things are timely, that they're provided in the least restrictive setting, and that they are both accessible and also available across geographic locations, so that whether it's a person in the community that's able to access those facilities 24 hours a day, 7 days a week, or there's different kinds of resources, or there's transportation to those basic kind of resources. We want to make sure that we're not setting up a system where people get stuck and there's not a way out of that particular system. So always making sure that we're looking again at the flow, that we're managing transitions, and we have intentional transitions, and that staff have training across the system of mental health, substance use disorders, but also acquired brain injury and intellectual developmental disorders and other disabilities. If you go to the next slide, please. I mentioned before law enforcement being the role of both a warrior and a guardian. We just want to be mindful that that's taking place, and that we want to support law enforcement to be able to do their job, or also to use those kind of abilities to be able to deflect folks by having community-based types of opportunities. Here in Denver, we have a lot of crisis services that are in our libraries, for example, so that the libraries can and the clinicians there and peer services can help identify and work with folks without actually having to call law enforcement in. If you go to that next slide, please. So when we think about police diversion, it's important that we have all the different kinds of services, the right response, the right place, the right time with the right people. I'm not going to go into all of these, but just want to note a couple of things. Across the country, CIT, or Crisis Intervention Team Training, is an ongoing effort to be able to help police understand de-escalation through a mental health lens. Also training for mental health first aid. I would also advocate that there needs to be training again around intellectual developmental disabilities and also acquired brain injury. Being able to use, again, those 911 codes to understand where to respond, what kinds of crises are coming in, and then how to best respond to them. LA County has done one of the best jobs, I think, in creating a standardized observation form that has all different kinds of situations that they run into, and then giving that observation form, whether it's to a crisis stabilization center, to a hospital, or to the jail, to be able to let folks know this is what we just saw with this particular person that we've encountered. Making sure that any drop-off center, any stabilization center has a no refusal process so that they can actually work with the person and problem solve from there, and not having police being waiting for services. And again, making sure that we're doing intentional case management as follow-up, that we're addressing the needs of most visible persons, and that we have intentional transitions between folks. Please go to the next slide. Just want to note that all those things I just said, this slide has a lot of meaning in that a lot of times most of our systems are not adequately set up to deal with all those different kinds of factors, especially persons with complex needs. And so oftentimes we have a center, but it's limited in what it can actually deliver. So we want to make sure that we're setting up systems that really can manage all the needs of folks. If you go to the next slide, please. A simple way of looking at this is this diversion equation is really about what do first responders do differently, what do treatment providers do differently, and then system change. So part of that is not just first responders as in police, but again, also fire may be really good first responders. Really looking at how emergency services are responding, and making sure that we're always offering both that way of doing their job as well as looking at it from a clinical lens. If you go to the next slide, please. So having collaboration and relationships is really the way to do this. And that starts with doing some cross-training, having the discussions, having everybody at the table. And you'll hear in this particular presentation about how 3 different communities have been doing this work, making sure that we're really talking about coordinated services. I often refer to something called the MET, money, ego, and turf, and making sure we're always managing those particular issues, having persons with lived experience at the table, and making sure that we're really building sustainable partnerships. If you go to the next slide, please. This is just a few of the different folks that you might want to have at the table from different lenses. Everything from your social service departments, making sure that people have access to entitlements, bringing in veteran services, and basic kind of primary care healthcare systems. That might be a CCBHC, a community mental health provider, an FQHC, hospital systems. If you go to the next slide, please. Managing funding silos, really understanding addressing limited resources and being very creative around those, and then also understanding system cultures and what some regulations may prevent in some respects, but also opportunities that they bring. If you go to the next slide, please. Peer supports, you're going to hear any work that PRA does always advocating for looking at peer supports. And so we created this document and looking at peer supports and those roles across the sequential intercept model. We invite you to look at this particular slide in more detail. These slides will be available to you later on. We're really looking at how do you maximize and leverage persons with lived experience and what they can do to help, and in particular around engagement of folks in this system. If you go to the next slide, please. Another big issue that we see across the country is around housing, and I will always say stable housing is treatment. People have to have a stable place to be in order to receive services. So it's very important that we're looking at stable housing, that we have a continuum of housing options, that we're not just thinking about shelters as being kind of a place to be, but what we're doing there, how we're bringing in care systems there, but also rapid rehousing all the way through home ownership. Maximizing, leveraging waivers and different kinds of opportunities from different funding resources, and always, of course, honoring Olmstead Act. If you'll go to the next slide, please. Also want to just recognize the role of supported employment, that there's more and more efforts to really look at how do we help people be employed at their level of ability. So always looking at ability, adaptive functioning, and what we're doing to help people be successful in their work environment. Next slide, please. And then back again to data collection, understanding how information can flow through your system. How are you right now sharing information? Are there ways to make that more timely? Are there consistency around release of information? But how do you look at how people are flowing through the system? What information do we need to know about them? Understanding that many places have transactional data systems that aren't really set up to do analysis or even trending. So really looking at your data systems, how's information being shared? What are those opportunities to create a new way of looking at folks? And the last slide that I have, and then I'm going to hand it back to Lisa to introduce 3 different communities to talk with you about their work, is just to recognize that it's important to have a formal planning group. You want to formalize the work of that group through charters and memorandums of agreement or understanding. Really, again, looking at your information sharing, really addressing outdated kinds of regulations and policies, always making sure that things are trauma-informed approaches and trauma-specific services, and then integrating all your different kinds of services into the different kinds of parts of your system, always thinking about who could be a partner, and then making sure that we have peers and addressing issues around housing, transportation, and employment. Lisa, I'm going to hand it over to you to introduce our first group of panelists.
Thank you so much, Reggie. That was so thorough and comprehensive of what what cross-discipline system looks like when we're dealing with the intersection of behavioral health and criminal justice. And I kind of want you in your mind to kind of think of what Reggie just presented to be kind of the theory, right? And now our panelists are going to kind of show us how they put that theory into practice, thus the title, Diversion in practice in Intercept 0 and 1. So our first panelist we'll be hearing from is from Middlesex, Massachusetts. And back in 2018, the Massachusetts legislature passed an act relative to criminal justice reform, Chapter 69 of the Acts of 2018. And within this act, it contained a provision creating the Middlesex County Restoration Center Commission. The act directed the commission to research the gaps in behavioral health and criminal justice diversionary services that led to a disproportionate rates of arrest and hospitalization of individuals with behavioral health conditions, and then charged them to identify a model for behavioral health and social services that could fill these gaps, and then to ultimately design and launch a pilot of such services over the course of 4 years. So without further ado, I'd like to hand it over to our Middlesex panelists. Thank you so much for taking the time out today to discuss your efforts in Middlesex to this field-wide webinar, and I will allow you both to introduce yourselves.
Thank you. Thank you, Lisa. I'm Donna Mosh, and I co-chair the Middlesex County Restoration Center Commission, along with Middlesex County Sheriff Peter Katusian. And in the other parts of my life, I am president and CEO of the Massachusetts Association for Mental Health, and I am the court monitor for the U.S. District Court of Western Washington, overseeing court-ordered reforms in the True Blood matter involving people for whom there are questions of their competency to stand trial. I'm pleased to be here today and pleased to be here in the company of Katya Sharp, who staffed our commission from the start ably and is now heading up an initiative in Massachusetts to eliminate the Medicaid inmate exclusion, but I will turn it over to her to give a further introduction of herself, and then I will start with the first slide.
Hi, my name is Katya Sharp. As Donna mentioned, I've been staffing the Restoration Center Commission for about 3.5 years now, and work for Commonwealth Medicine, which is the division of the UMass Chan Medical School here in Massachusetts. So pleased to be with everyone, and Donna, take it away.
Great. So you gave such a great introduction earlier about the genesis of our project and our efforts. I want to step back for a moment and say that there was a definable problem in Middlesex County and frankly all over the state, but the energy organized around Middlesex County as a place to try to begin to solve this problem, and that is that police report a high percentage of officer time, you see the figure here, spent on calls related to behavioral health conditions. Contrary to that percentage of time, they anecdotally report the number of cases, as we'll discuss later, that are actually cited in documentation of all of the emergency calls is somewhat less than that. In addition to the police believing that they are more busy than they would like to be with addressing people with unmet behavioral health needs or who are in crisis. Half of all the people incarcerated in Middlesex County in our House of Corrections have mental health conditions, 80% have substance use conditions, and 75% have co-occurring conditions. And that's one part of the problem we're trying to address, the overrepresentation of people with these conditions in the jails, the high percentage of time police are occupied with these cases. And then the third is that we have a disproportionate number of people occupying emergency rooms, seeking to have their crises managed. As was very thoughtfully said earlier, if you don't address a crisis, it will turn into an emergency. And although, as you see the data here, 14% of ED visits in the state are for behavioral health conditions, nearly 3/4 of them are people who end up boarding, which we define as waiting for longer than 72 hours to be admitted to a bed after being screened for the need for inpatient care. And you can see that we've cited, just for a point of comparison, the average cost of arrest versus the cost of a mental health emergency department visit. Not only is it cheaper to arrest people, I think the more important thing that we learned from our police is that it's easier for them. They can quickly dispose of somebody by dropping them into their jail, whereas if they take a person to an emergency room, they have to wait to have their drop-off signed off by the ED, have somebody effectively accepted by the staff, and they find that too time-consuming and too burdensome. This is not unlike similar situations in other jurisdictions in the country. So this act did pass in 2018, and really the genesis of that was that advocates got together wanting to do something about the problems of overrepresentation of our people in the criminal legal system, and also the problems with ED boarding. And they had a good working relationship with the sheriff of Middlesex County and decided to focus there on trying to develop a reform initiative. And from the very beginning, they were intent that there would be a representative group of people appointed to a commission. So we have stakeholders from really all of the areas of interest in the justice system and the criminal legal system. We have the trial court and the police. We have probation and parole. The legislature, of course, is involved because they filed this legislation, and actually we have incredible legislative champions who were behind the filing of the legislation and who continue to sit actively on the commission. Behavioral health providers are at the table. We also have representatives, high-level representatives of the Commissioner of Mental Health, the Secretary of Health and Human Services, the State Medicaid Director, and the Department of Public Health Bureau of Substance Abuse Services. So we have a very good group. We have advocates also on that group. And together, they have really worked using data to inform decisions to come to a conclusion about a model design. I would say that started, just to be brief, if we could go to the next slide, in our first year, we did an environmental scan and gaps analysis and needs assessment for Middlesex County. And a lot of that was done by staff, meaning Katya, as well as apt associates who we hired as consultants to work on the project. And many members of the commission brought together their knowledge, their resources, their reports, their data to help to inform that analysis. So in the second year, based on the analysis, we mapped out a model. And I would say a couple of things about that. We also looked to what we learned from the literature, what we learned from getting expert input into the process, and visiting other model programs to really frame an appropriate model for Middlesex County. The second aspect of that, besides the data and evidence that went into the development of the model, was considering how the model would fit into the landscape of service delivery and the structures anticipated for future service delivery reform in Middlesex County and at large Massachusetts. So in year 3, we worked to really refine that model based on emerging information from the administration about a behavioral health ambulatory care redesign, which included, for the first time in the mix of services, urgent care, urgent behavioral health care. And it also included the designation of comprehensive community behavioral health organizations, which we're calling community behavioral health centers. And we pinpointed the importance of really embedding our model into these structures to optimize performance and accessibility for the people we most want to serve, and also to optimize the opportunity for sustainability. I would just say that we are in year 4. Pilot implementation is just around the corner. We have a request for proposals in process to solicit a provider to take on that implementation. And we will be measuring from the beginning, as this future note says, with an eye towards both, documenting and being accountable to outcomes, but also what we need to learn for replication and scale. So I'd like to turn it over now to Katya, who is going to talk in more granular detail about some of the data gathering, some of the results of those efforts, defining the target population and presenting unnecessary hospitalizations and preventing arrest. Katya, take it away.
Okay, we can go to the next slide, please. So we spent, as Donna mentioned, the first several years collecting information and really trying to figure out who is our target population, who are the people who are getting arrested currently by nature of behavioral health needs or social service needs, or who is going to emergency departments unnecessarily. And what are kind of the parts of the pathway and the steps in the pathway that cause that to happen. So we went around and talked to our police departments in Middlesex County. We're a rather large county. We have 54 cities and towns with as many police departments. And we asked them, do you flag in your database your behavioral health 911 calls? As you can see here, some do, but we're not identifying nearly as many people who, as the anecdotal evidence might suggest, in terms of the viewpoint of street officers believing that the bulk of their time is spent unnecessarily dealing with folks who have nowhere else to go for services. We also did a deep dive on data in 2 departments, Arlington and Bedford here in Middlesex County. And again, we really identified a small number of those 911 calls that are attributed to behavioral health. And I think that speaks more to the need for improved data collection processes more than it does the actual number of people or volume of people who are the subject of these 911 calls. If we can move on to the next slide. We also looked into preventing unnecessary hospitalization, and we got some data about the current crisis service system here in Massachusetts, which I think we are lucky in that we have a fairly robust crisis service system already here. There are emergency service providers, or ESPs, that do crisis stabilization on site and also have mobile crisis teams. And this information is from Middlesex County around what's currently happening with crisis services. So what we found was that despite 75% of callers to those services being callers who are calling about themselves or a family member who's in crisis, the location of the assessment that's happening is actually 89% of those assessments are happening in an ED setting. And then after those assessments happen in an ED setting, 30%, which is a large number, are ending up in outpatient aftercare supports. So they're not going to acute settings. So how do we interrupt that cycle? How do we interrupt the system that's sort of moving people into ED settings unnecessarily as well? Next slide. So then we really did a lot of analysis about how do we interrupt that cycle by creating decision systems and transportation systems that get people to alternative services instead of getting arrested or going to that ED setting. So we asked police departments if a restoration center existed, and we also looked around the country at national models for these things. You'll hear from Tucson later, which was kind enough to host us and show us their model. But if there was a restoration center modeled on some of these national programs, would the police use it? And we got overwhelmingly, yes, police would use this model. So the number one reason why they said they would like to use such a model is for voluntary ED diversion. But many police departments also said that they would use this model for arrest diversion, including for high-level offenses. We actually separated out low-level and high-level offenses, assuming that there would be less of an appetite to divert those high-level offenders. But we are finding that, over 25% of departments say that they would consider diverting those offenders to a restoration center. We also tried to figure out what's the pathway to a restoration center. So we asked police departments, how would you prefer people get transported after a 911 call to an alternative crisis center instead of an ED or arrest setting? And police certainly prefer some type of locked vehicle, but they don't necessarily prefer their own vehicle. They prefer folks to go in an ambulance, perhaps, to get to a restoration center. So really trying to keep all of this information about how is police decision making and 911 decision making happening currently, and how can we interrupt those pathways. Next slide. And so all of that culminated in the development of a model restoration center that we thought really took the best parts of all of the models we saw nationally and really addressed the specific problems that we're seeing in Massachusetts. So triage and assessment certainly needs to be a component. That's a key element of a restoration center model. But also we felt like crisis stabilization was a necessary element for us. And adding an element of sober support, which is not a level of care that currently exists in Massachusetts, was very important for us, given the high and increasing rate, especially of opioid use disorder going on in the community. And then we felt like respite was a key element in other sites that we viewed, especially in terms of helping to really create that backdoor into a continuum of services that acts like Velcro to keep someone in community settings of care instead of getting arrested in the future. So we've shown sort of all of the different levels of care that create that behavioral health continuum that we're really looking to link people up with on the back end of our model. So I'll hand it back to Donna to talk about what we're doing next.
Thank you, Katya. So just one reminder about something I said before as Katya described the model, that we really did design this to be embedded in the community behavioral health center structure and the roadmap that the Executive Office of Health and Human Services has for redesign of the ambulatory behavioral health system. And we are very mindful, of course, that this will be a cross-systems initiative. And so in support of all of that, we took steps in the legislative and budgetary process to do several things that we believe would support implementation. We established a trust fund where we could hold grant revenues, state revenues, and carry any savings over from one year to another, so that we could pay for the parts of the restoration center that are not covered by the Medicaid program. We did establish a financial model, as you see here, that indicates what the total direct expenses would be to operate for a year, the administrative overhead, et cetera, and what revenue we thought we could expect from Medicaid billing, and also billing the Department of Mental Health, which funds respite beds out of a separate fund from the Medicaid program. So we've identified what we need to raise from philanthropic grants, which we're in the process of doing. We've been given a federal earmark in one chamber of Congress to help boost this effort. And then we have a state appropriation for the year to support the ongoing work of the commission and to fund the initial implementation. We obviously have more to do, but we're on our way. The other thing I would say is that we funded two pieces of legislation, one to reform 911 and the other to implement 988 in ways that would support and sustain the efforts of the Restoration Center. For example, Katya described the problem we have with the lack of data and clear reporting about which cases coming into 911 are behavioral health cases. If this is going to work well, 911 operators are going to have to be better informed about how to identify a behavioral health case and either direct a call over to 988 or over to the crisis system or elsewhere. And so part of the 911 reform legislation is to provide grants to municipalities for their local 911 providers to do training for staff, to develop new scripts for the call centers, and to provide expanded support so they could be a vital and collaborative part of a reform system. Similarly with 988, there are regulatory reforms and levies to support the financing of stand-up capacity for taking 988 calls and having that linked to the roadmap's revised crisis services design. So all the way around, we're trying to tackle this in the legislature, with the administration, with our courts, and we are, as I said, fortunate to have all of those bodies not only represented on the commission, but as active participants in the commission. So I'll stop there and thank you all for your time today.
Thank you very much, Middlesex. We certainly appreciated that chronology of events that took place in order to get to where you are now. There was a problem that was identified and an opportunity, actually, and you have developed solutions that are not only intertwined with best practices, but did the necessary research that it took to provide the data to show what that opportunity was to help folks with behavioral health in the criminal justice system effectively not only move through that system, but almost prevent penetration into the criminal justice system. So we wish you well with the Restoration Center. And so anybody in the audience, if you have specific questions for Donna or Katya, please put them in the Q&A, and time permitting, we will get to them at the end of this presentation.
And Lisa, I would just underscore one other point, which is because of the approach we took and the engagement of diverse stakeholders, we really built a consensus model, and we have the diverse support we need to carry this through financial efforts and regulatory efforts for reform and implementation.
Thank you. Yes, thank you for pointing that out. Okay, we are moving on to Pima County. And really briefly, Pima County has been doing what we all have been learning about for quite some time. They have had contributions from local mental health and substance use providers, various criminal justice partners, additional stakeholders that are too numerous to even name. But with the collaboration that they have been able to conduct within their county, they have consolidated very solidly their integration in the continuum of care for the people who they've served. Pima has participated in the MacArthur Foundation's Safety and Justice Challenge, which has allowed them the development and enrichment of connections with partners and stakeholders. And that's absolutely proved invaluable to growing a sustainable program within the county. Their results demonstrate that working together produces dramatic reform. They have common goals within their stakeholders, and they are always continually finding ways to collaborate among cross-system partnerships, and will be saying to you and showing you that the regular meetings that they've held and the communication channels that they have established truly has set them apart as one of the premier counties within our states that have really gotten a hold of this diversion practice within the Intercepts of 0 and 1. So without further ado, I'd like to hand this over to Pima County and allow them to introduce themselves prior to their presentation. Thank you.
Thank you so much, Lisa, for that introduction. We really appreciate it. You can go on to the next slide and people can peruse our points while I introduce our team here. We're really very pleased and privileged to be invited to join you all today. My name is Kate Vesley. I'm the Director of Justice Services for Pima County, Arizona. Along with me, I have Dr. Margie Balfour, who is the Chief of Quality and Clinical Innovation for Connections Health Solutions, which is the vendor for our Crisis Response Center. Sergeant Jason Winsky is with Tucson Police Department's Mental Health Support Team, otherwise known as our MIST team. And we also have Johnny Gasper, who is the Director of Justice and Crisis Systems for Arizona Complete Health, which is our Regional Behavioral Health Authority. Next slide, please. And we're going to try and move along as quickly as possible so we can get to George as well. While you're looking at our calendar here, I wanted to highlight, Middlesex actually came out to visit us not too long before the pandemic happened. It's really great to see the growth and the amazing progress that they've been making on theirs. When you look at the system that Pima County has in place, it's important to know that this didn't happen overnight. It was a very long progression that allowed us to get to where we are today. Our community is somewhat famous for our relationships between our systems. Tucson is a big city. It acts like a small town. And so much of what we have accomplished is thanks to the genuine collaboration that has been sustained for years and years and years among our justice system, treatment partners, and all the spaces in between. Our systems are built on what processes are put in place, but also what processes happen when something goes sideways, that you can actually pick up the phone and I can call Margie or I can call Johnny and say, this is what's happening. How do we work on it? How do we fix it? Pointing fingers is not something that's ever really played out well here in Pima County, and as a result, our culture of investment in this work and our passion and our culture of accountability has really helped our innovations to stand the test of time. And next slide, I'll turn it over to Dr. Balfour.
Hi, and so thanks for having me. And to piggyback on what Kate said, really what everything is about is relationships and how the different parts of the community come together to work on common goals. And, this slide just sort of talks about there's things that may seem like competing goals, but we're always, whenever we see like a this or that, we often ask, well, why not both? And that includes when you talk about law enforcement and, and kind of going along with that guardian versus warrior is, why can't you focus on health needs as well as justice needs? Next slide. And actually, a lot of what we've been able to accomplish is it's built on a foundation that gives us the structure to actually have oversight and governance and accountability. And so I won't go over all the teeny little details, but basically, the way it works in Arizona is that we've always had managed Medicaid, and our managed Medicaid braids funding in from different sources. So Middlesex talked about having to be sustainable and looking at, things that are not funded by Medicaid. What Arizona does is it leverages those sources very well. So they take the Medicaid funds, they take the SAMHSA block grant funds. There's a state line item for crisis. Some of the counties have funds for crisis. And that all gets braided together into our Medicaid department, which is called Access. And then they put out for competitive bid to be the Regional Behavioral Health Authority and take all of those funds. And then they're responsible to administering the behavioral health system for that region. It's 3 regions for Arizona. We're talking about the South, which is the dark part. And they're responsible for their region. And so Johnny Gasper's here from the REBA, which I sometimes call him our benevolent overlord, because what they do is they act as an accountable entity that really makes a central place for planning, strategic planning, governance. They bring together people to collaborate, and they are able to align all the different services towards common goals because they contract with all of us service providers. So we have a contract with them. The mobile team people have contracts with them. The crisis line has contracts with them. But since it's all administered from a central point, then you can actually have people thinking about all these things as a system and how they work together. Next slide. And an example of that is if you look at, one of the things that is really unique and great about crisis is that the clinical goals and the financial goals, which are things that are often sometimes at odds, for crisis, they're really closely lined up. Because what I want as a psychiatrist is I want my patients to not be in the jail for, if they've got a mental health issue that is what landed them there. I want them to not be in the ER because, as we've all talked about, that is like not a good place to get psychiatric care. And don't want them to be locked up in the hospital if there's a way to keep them stable in the community. If you're paying for stuff, you want those things too, because it's a whole lot less expensive to have people doing well in the community versus in these really restrictive levels of care. And so this is a great example where what is clinically the best thing to do is also the fiscally responsible thing to do, especially since a lot of this is funded by taxpayer funds. And so especially those of us in red states, you want to talk about responsible stewardship of taxpayer funds. So kind of an example then is if you look at all of our crisis services, you can line them up on this continuum of restrictiveness, intense service intensity, and cost. And so kind of at the far end of the spectrum is, what's the easiest thing to do out in the community is pick up the phone and call somebody for help or text. And so we have our crisis line. And the crisis line gets about 1,000 call or 10,000 calls a month. And they are able to resolve 80% of those on the phone. And they do that via telephonic counseling, crisis intervention, safety planning. But they also have, because it's all managed under this REBA, Regional Behavioral Health Authority, the REBA requires the clinics to put appointments into the software that the crisis line has. So if it's like 2 a.m. and part of what's going to help someone's crisis and help them, hold on until the next day is to know that you have an appointment at 11:30 tomorrow, they can do that. They can actually make that appointment in the middle of the night. If they can't resolve the crisis on the phone, then they are able to dispatch mobile teams. And Pima County has around 16 mobile teams operated by a couple different agencies. But again, because we have this central oversight structure, they have the same phones and same GPS software, even though it's one company that is the phones and then 2 different ones that are the mobile teams. So it's all coordinated. It's like Uber. There's like a map with the blinky dots. And so they can dispatch a mobile team. And the mobile team's usually 2 clinicians. If they do a face-to-face, they resolve the crisis about 70% of the time. And if, for those that are even more acute, then we have our crisis facilities. And I'll be talking about the Crisis Response Center, which is kind of the main one for Pima County. And in these crisis centers, they typically have 23-hour observation function. And folks who go through these centers, even though they pretty much meet hospital requirement for inpatient, these are the people that would be boarding in emergency rooms if not for these facilities. Most of them, 60 to 70%, are able to be discharged to community care the next day. And then we have post-crisis care. So we have, there's wraparound services that work with people, a lot of peer-based stuff to make sure they get connected to where they need to go. They're called second responders. We also have crisis residential for people who need a stable place to be, while they're still, because the crisis doesn't just flip off like a light switch, so for during that time. And then the data that, this is data from Arizona Complete Health, REBA, most of those, 85%, are stable in community-based care for the next 45 days, meaning that they're not going back to the emergency room or crisis facilities or hospitals. Now, at every point along here, there's easy access for law enforcement. So this is where this sort of Intercept 1.0 stuff kind of comes in, where and this collaboration is like baked into a lot of the contracting and the protocols. So at the crisis line, they've always had a dedicated line that law enforcement can call to directly get a supervisor. But for the last couple of years, they've had a co-location program where there's crisis line staff that co-locates with 911. Some of that's virtual now because of COVID, but they have access to the dispatch system and they can clear calls. And So that's intercepting calls as early as possible and shunning it down of clinician only route. So that people talk about co-responders and stuff a lot. We try to do that even more upstream, so that you're only sending law enforcement if they really need to be there. And then with our mobile teams, we have, again, like there's incentives built in. So like if I call looking for if I need a mobile team to come to my house because I'm in crisis, contract says they have an hour to get to me. I think the average is shorter than that. It's like 40 minutes or something. But contract says, though, if law enforcement's in the field and needs a mobile team to come out there and help them with something, then they have half that time. So that kind of bakes in incentives to treat law enforcement as kind of a quote preferred customer. We do have co-responder teams as well, which Sergeant Linsky will talk about later. But those teams are mostly focusing on outreach and follow-up, so kind of that post-crisis stuff. And then our crisis facilities, I'll talk about in more detail. They really are set up to be easier to use than jail, so that law enforcement prefers to come to jail rather than come to us rather than take people to jail. Next slide. But to the officer on the street, it's not all lined up like in my little schematic, where all the little pixels are lined up perfectly like that. To the officer on the street, there's just a bunch of services. And so that's where this concept of no wrong door comes through. I mean, our officers are pretty sophisticated in terms of knowing where people need to go, but they don't need to know all of this detail. They just need to take the person where they think they need to take the person. And then our no wrong door culture is, we're not going to say, oh, you took them to the wrong place, go on this wild goose chase and get them somewhere else. We accept that person or do what we need to do to get the person to where they need to be without putting the patient or the officer in the middle of some kind of power struggle that they're at the wrong place. Next slide. The centerpiece is our crisis response center. This was built by Pima County with bond funds back in 2011. We've been managing it at Connection since 2014. And along with that sustainability theme that you heard from Middlesex, it's critical to build something like this with that in mind. And so the county did the bond and raised however many millions of dollars it was to build it. And they own the building, and then they lease it to the REBA for like $1 a year, which is like the best rent ever. But all the services that are in there come via that structure I showed on my first slide, which is through the Medicaid system with other funds braided in. So it's the county's not having to foot a bunch of money every year. Because and this is another little of my soapbox issues. Like, we wonder where the money's going to come from for crisis services, but we never wonder that if someone has a heart attack or a stroke. And so a mental health emergency is an emergency just like anything else. And so it should come from the healthcare sector. And so that's how it's financed. It is, sorry, my cat wants to talk to you too. It is the law enforcement receiving facility with this no wrong door concept, meaning we take everyone. We have our 24/7 urgent care clinic where you can walk in, get a med refill type thing, and then be in and out in a couple hours. We have that for both adult and youth. We have 2 different 23-hour observation units, one for adults, one for youth. And then for adults that need to stay a little bit longer, we have a subacute unit with 15 beds. It's on a part of a cool campus where the call center is in our building. It's connected to the emergency department at the county hospital next door to us, which is run by Banner University of Arizona. The bond also built a 66-bed inpatient psych unit that Banner runs. It's where most of the involuntary commitments go. And there's a mental health court right there. Next slide. And really, this idea of law enforcement's preferred customer, it really, that's what you need to make this kind of thing work. And so what do officers not like? They don't like to wait. They don't like to be told they're at the wrong place and take this person somewhere else. They don't like taking their guns off. So they have their own entrance where they can get in and out as quick as possible. At one point we were told it takes 20 minutes to book somebody into jail. I think it actually takes longer, but our goal is 10 minutes or less. And for the last few months, it's been around 4 or 5 minutes. So we really are getting them in and out, so it's easier for them to drop off to us. The other thing is we take everybody, and we mean that. There's no such thing as too agitated, too sick, too intoxicated, too violent. We actually want those people with us, and we don't use security with them. It's all our own staff. But we feel if you turn them away and they go to an emergency room, they're going to get restrained there because they're not set up to handle them, or they're going to go to jail. And we think that we have the right setup where we should, the most agitated, violent folks should come to us because we're the ones that are best handled to equip, to take them. Next slide. And then for this, I'll hand it over to Sergeant Wensky to talk about all the cool stuff that TPD is doing.
All right. Well, hello, everybody. My name is Jason Wensky, and I'm the sergeant of the Tucson Police Department Mental Health Support Team. And we are a small part of this whole model that you are hearing about, but we are the law enforcement component. I will just very briefly talk about the things that we do. We started 7 years ago with myself and just 2 officers. And I think what I really want to focus on right now is what Kate and Margie both said, which is it took a lot of years and a lot of time to build the systems that you see on these slides and what we talk about. To briefly explain, we are a dedicated law enforcement team, not designated, which means mental health is all we do. We serve all of the civil commitment orders, whether it's a voluntary transport or involuntary transport, people that are on what we call court order treatment, or what people hear a lot around the country is assisted outpatient treatment, or AOT. We call it COT here. So we do all that. We are what we like to call the CIT model in action. And that's what you see on the left side of the slide here. We are a low and slow approach. I'm stealing that phrase from Kate. We go and we take our time. We're not tied down to 911 calls. Like I said, this is all we do. And so when we're out there serving the pickup orders, we can take as much time as we need to make sure that we do it in a very patient, methodical and compassionate way. We also have an investigative component of our team, which provides kind of that wraparound and follow-up approach for our friendly faces, or I like what someone said earlier, the MVPs. Next slide. So after we started our mental health support team, the next thing that we did a few years later is we started a substance use resource team. And that is a deflection model similar to what you see in places around the country like Seattle. In Tucson and in Pima County, we are able to divert people who have simple possession of narcotics to on-demand MAT clinics. And then our latest and greatest thing is our homeless outreach team, which also operates in a co-responder model with Housing First navigators. Next slide. So this kind of shows some of our co-responder model. And I think this is my last slide. So I think what I want to just kind of end on here is that it really is, and you've heard this throughout our presentation, it really is a collaboration. None of what we do, whether it's our mental health team, our substance use team, or our homeless outreach team, would work without Margie, Kate, and Johnny, who are on the call, without our REBA, without an on-demand CRC that has a no wrong door policy. We are, yes, an important part of the SIM model that you see, but we would not be able to divert people to treatment if those treatment options weren't available and they weren't funded and they weren't operating under a no wrong door policy. So with that, I think it's my turn to turn it over to Georgia.
Thank you so much, Pima. Thank you very much for sharing your system. And I'm certain that there'll be questions that are coming in that if we run out of time, we will get them over to you and send them back to the audience. But without further ado, I know we have just a few minutes. We will end on time. We'll have about 5 minutes for Q&A. Up next is Athens-Clarke County in Georgia. We are joined today by the Honorable Judge Sweat, Katie McFarland, and Sergeant Roby Cochran. And Georgia has received multiple, Athens-Clarke County has received multiple JMHCP grants throughout the years and kind of really set the tone for other counties within Georgia to go after JMHCP grants, and also has been a model for Fulton County, Newton County, Macon, Bibb County, other recipients of JMHCP grants. For in the interest of time, I'm going to straight back over to Athens-Clarke County. Thank you.
All right, thank you. And I'm David Sweat. I'm a senior Superior Court judge, and I'm joined today by Robbie Cochran, who is the Athens-Clarke County Police Department's lead co-responder and Katie McLaughlin, who is Katie McFarland, who's the director of the Justice Division of Advantage Behavioral Health, which is our local mental health clinic. Clarke County is much different from Pima or Middlesex counties. We're about 130,000. We have the major university here. We're also the smallest geographic county in Georgia, and we have a poverty rate of about 29%. And most children in our schools receive free or reduced lunches. So we've got a great university, but we also have a lot of challenges in the community. Our story is maybe a little bit different in that we began to see the need for collaboration about 6 or so years ago. We began to collaborate between our court system and the mental health providers and law enforcement in our accountability courts. And we started to build some relationships. And out of that, we realized that we needed to start working together to try and divert people away from the court system where it's ponderous and complicated and didn't necessarily always result in the outcomes that we looked. If I could show you the next slide, please. So this is what we found when we looked at what a mental health consumer might encounter when they came into contact with law enforcement and were arrested or otherwise detained. And we call it the spaghetti slide because it just shows how convoluted the paths of referral and the advancement through the system, what existed at the time that we started. And this was sort of a beginning for discussing how we could make this a better system that would facilitate the needs of justice-involved individuals with mental health treatment needs. And so we began an examination of what was the circumstances that we had in the community. And Robbie and Katie, if y'all want to talk about what we found out now.
Sure. Can we forward to the next slide? So this is about our collaborative that Judge Sweat just mentioned that brought together individuals from our court system, our county, the police department, our sheriff's office, as well as Advantage, which is we are the safety net behavioral health provider in the area. And we started talking about the gaps and barriers to services and resources and how can we develop something better in Athens-Clarke County. So next slide. So we did a jail study. We had a wonderful partner on our team who went into our jail and pulled a booking records for a 3-month period. And she took each one of those records by hand and ran it through our behavioral health record system. That is every name file, every arrest record, all of those things. It was a very labor-intensive project, but well worth it for the data that we received. So we did find around 38% of those individuals in our jail during this period were involved in behavioral health services at some point or had a behavioral health, mental health diagnosis or co-occurring disorder. This is probably low. This doesn't account for individuals who saw private providers, who were undiagnosed, who were new to the area, just those who had some sort of name file with the public behavioral health provider. Those individuals were staying 22 days in jail versus the general population who was in and out in about 8. They were returning to jail 53% of the time within a year. 53% were returning. And 91% had a previous arrest record. So they were going to jail more often, they were staying longer, and they were returning. Next slide, Robbie.
Yes, so the police department got all this data, and they basically came to me, command staff came to me and said, hey, we'd like to get the ball rolling on creating a mental health unit. And my reply was, great, what do you want to do? And their reply was, go figure it out. Luckily, I knew Katie, so I went to Katie and I asked Katie, I said, hey, Katie, you want to work with me? And after about a week, she agreed. But now we run into the problem, well, how? Because she's covered by HIPAA, I'm not. So we had to come up with a way to communicate. So what we did is I started going through police reports. 2017, I went through 18,042 reports by hand, looking for anything with a mental health tie to it. Out of the 18,000, I found 1,323 roughly that had a mental health tie to it. Then we broke down some additional data. We average age range. We were looking at criminal charges. I would send all that information over to Katie, and that's basically where that started.
And all of that was really to help us build a case for moving forward into a pathway and a model. So next slide, please. Again, this is just a little more on our jail studies and all the data that we collected and the recurring issues with lack of information, discontinuity of care, individuals going to jail more often. And so we came up with a co-responder model as a way to try to make a difference in our community. Next slide. So this is our new kind of recommended pathway. This is kind of how we got started. So changing that map that was very confusing to navigate into a more streamlined situation for officers and for individuals in mental health crisis that has a co-responder model, and putting a licensed clinician with a law enforcement officer answering calls and then diverting people into the correct place, such as the hospital, a mental health crisis center, 23-hour observation unit, all of those, avoiding jail as much as possible. Next slide. So we've been doing our program now, we kicked off in 2017. We actually have 3 teams now running calls. It has proved to be very useful. We go out on calls. It could be anything from a welfare check to an individual having a behavioral health crisis, and our teams are able to really take some burden off of our officers on the road. We can do follow-up, we can do outreach. It's very helpful because our clinicians are actually employed by the behavioral health agency, so we have access to a lot of information that we wouldn't have if we were employed by the police department. Robbie, would you like to say anything else about the model?
Yeah, like Katie said, we currently have 3 teams. Our 3rd team actually started, they've been in work for about a month. I think the most important thing we realized is we had to find the right people to pair together. I think if we'd have teamed different officers and clinicians together, it might not have worked, and we might not have the success that we've had.
And if I could talk for a minute about how I think our involvement with our local government contributed to that success. We started with a JMHC grant, and that is what we built our collaborative around. That's how where we got started with the study. And when we were, in the process, we met resistance from our county commission and other local leaders. But after we had the data that came from our jail, not national data about percentages or things that were somewhere else, when we had the data from our jail and said 38%, an undercount of individuals coming into our jail every year have mental health or substance abuse, behavioral health problems, it sort of, the light went off. And our commission is now funded, they're funded up to 7 co-responder teams. We now have created a cahoots type team that's just starting, but we call it our alternative response team. And we've gotten the buy-in and support from the commission and the community that comes from having information. So I think if you're thinking about starting a program, I think you need to do that reflective process that we employed to gather the information that's going to lead. Data drives decisions. And when you're talking about tax dollars and the competing responsibilities that public officials have, this kind of data drives them to make decisions that are better for the individuals that are coming into contact with the criminal justice system, but also better outcomes in the community and at less expense. So it is crucial to do that step before you begin the sort of starting your program. I think you need to know where you are in order to be able to do that. So I don't know if we've exhausted our time. I know we're short on time and you're trying to save a few minutes.
So this is your final slide, and then we'll move into some Q&A.
Oh, the key point to the final slide. Yeah. So we can go into Q&A if you would like.
Okay, thank you very much. All right, so before we answer a few questions in the Q&A, I'd like Athens and Clarke County to kind of talk about how invaluable it was for you to go to site visits in other parts of the country that had specific models, and then you going through the process of picking and choosing which would work best for your community.
Katie and Robbie, you want to speak to that and our visit to Lawrence, Kansas?
Yeah, I actually think each community, I think Katie and I, we've been to Gainesville, Florida, and talked to the university down there. We went to Kansas, and each individual team, they're basically doing all the same type of work, but what works in Florida, what works in Kansas didn't work here in Athens. So we had to kind of take what we learned from each facility and implement it here. Hey, what's going to work best for this community? So we took different pieces of different programs and just implemented it here. And it's constantly changing. What works here one week might not work the next week. So we have the flexibility to kind of alter our program as needs occur.
That has been invaluable. And still, just today, I'm hearing these other programs and I'm getting excited about what they're doing and trying to think about ways that we can tweak and add and adjust to improve what we're doing. I feel like there's constantly opportunities to improve what we're doing and learning from other programs.
Great, thank you very much. So this question is going to be to all of our panelists, Middlesex, Athens-Clarke County, and for Pima, and we'll run through a few, and probably this might be helpful from Athens-Clarke County, but suggestions. What are some suggestions on how to help politicians, community leaders better grasp the fiscal benefits of the right person at the right time?
One thing is quantifying, the cost at the jail for an individual, a justice-involved individual with behavioral health needs. And they may have an average dollar amount of what they think it costs, but when you look at the extra treatment needs, the medication expenses, and the challenges that individuals with mental health or behavioral health needs present, you need to move it out of this is just an ordinary individual who's in jail to this is an individual with issues that make them more vulnerable and more expensive in how we respond to them while they're in confinement, and then pointing out the impact it has in the community when we can divert people and prevent them from going to jail on a regular, repeated basis. Data-informed
decision making. When leaders and politicians find out exactly how much it costs per day for somebody with behavioral health disorders inside their jail compared to somebody with classified in the general population, that kind of moves folks, especially when you have that hard data. All right, so Pima, did you develop any recommendations for how to record better data about behavioral health related 911 calls?
That's definitely a question for Margie. She is the data expert of our community.
That's a Johnny question around the 911 though. He's over that.
Yeah.
Yeah, happy to answer that question. So we do a few things. We do regular data reviews twice a month with our 911 communications partners. So we meet with them to go over how those symptoms are presenting on our end and how those transfers are coming in, because we recognize that we're tracking them slightly differently than they're put into the CAD system, right? And we try and crosswalk that to identify how the symptomology is presenting both on the 911 comm side as well as on our crisis line side, and matching the triage to create some generalized discussion points and work out how we can identify them more effectively.
And I just wanted to jump on that previous question about talking about the costs. We talked a lot because of the audience here around cost of justice system, but also don't forget there's cost to the healthcare system, and state legislators, like the two largest pieces of a state budget are Medicaid and education. And we did an analysis with the REBA up in Phoenix, a facility up there too. And they estimated that 40% decreased Medicaid spending by 40% to have crisis facilities, in their system. And we're working on some research to better be able to answer some of those questions. But not just don't forget healthcare. Again, like it's a parity issue. Like there's laws in the country that say you have to have equal coverage for mental health, and yet we're wondering how we can get municipal and justice budgets to be redirected for mental health emergencies where, insurance ought to. In Arizona, with our wonderful model, if somebody with Blue Cross comes through our system, ultimately they get services, but it gets paid for by the funds that are meant to be for indigent people with no health insurance.
Yes, I think that too often than not, we forget about that medical piece, right? And the costs associated to that and the savings from restoration centers and crisis centers on the Medicaid side. Thank you for that, Margie. All right, Massachusetts, we have a question for you. Could you all please provide a resource detailing the 911 reforms in Massachusetts? So if you could send that over to our point of contact at CSG, we'll go ahead and get that out to everybody who has tuned in.
We'll send you both pieces of legislation.
Okay, thank you. All right, we are at the 2:30 hour. Julia, I'll kick it back to you.
Thank you, Lisa, and thank you all panelists for the fantastic presentation, discussion. I really want to thank you all for your time and really thoughtful insight that you've shared today. I also want to thank our participants for sending great questions into the chat. We will be following up with a recording, and if you do have any additional questions or concerns, I will also be sending a survey as well as a request for training and technical assistance link. Because we are at time, I'll run through very quickly, as you will see in the recording, our further contact information. So of course, if you'd like to connect directly with any of the panelists or any of the presenters from PRA or myself, so don't feel, if you need to, don't feel any rush to write these down or anything, but you will receive this as well. And then I did want to share, and you'll be receiving this as well, some additional resources that our panelists have also been involved in writing and analyzing. And so we're very lucky to have them here today. And finally, I just wanted to give a reminder to register and participate if you haven't already in the Taking the Call National Conference that is happening next week. And with that, I just want to say thank you. Thank you again to the panelists, to the audience, and to PRA for a fantastic presentation and facilitated conversation. I hope you have a great rest of your day, and thank you again. Right, bye-bye, everyone.
Bye-bye.